Never agree to this. 5 deadly surgeries for seniors. For too long, a deeply ingrained societal belief has held that when a seasoned surgeon recommends an operation, it is unequivocally the correct path. The doctor, after all, possesses the profound knowledge and expertise. The hospital is equipped with the necessary cutting-edge technology, and the administrative hurdles, the ready paperwork, merely await a signature. This perception, often leading to a passive acceptance of medical advice, was one that I, Dr. Mandell, shared for a significant portion of my career, until a different kind of observation began to reshape my understanding. A stark, sobering count of patients whose lives were irrevocably altered, not improved, but fundamentally changed after undergoing what were presented as routine procedures. Consider the individual who, seeking relief from persistent back pain, walked into the hospital with the hope of regaining mobility, only to emerge permanently incapacitated, no longer able to walk at all. Or the courageous woman who endured and technically survived the rigors of open-heart surgery, yet was subsequently robbed of 6 precious months of her life, grappling with a cascade of severe complications that no one had ever prepared her for, complications that remained unmentioned in the preoperative discussions. What remains largely unspoken, a critical truth often obscured by the gravity of a medical situation, is this fundamental physiological reality. As the human body ages, its inherent capacity to withstand the profound stress of an operation diminishes significantly, requiring a far more strenuous fight simply to survive the surgical intervention itself, quite apart from combating the underlying disease or condition. My extensive experience spanning decades in the operating room has illuminated these profound truths, compelling me to share what I consider to be an essential, indeed life-altering conversation about 5 specific surgeries that, for individuals navigating life beyond the age of 60, carry serious, often hidden, risks. Before delving into the specifics of these procedures, it's imperative to address one foundational concept, as it underpins every piece of advice that follows. If you are over 60, or if you feel the encroaching physical realities of 60 on the horizon, and your ultimate desire is to embrace a future defined by longevity, robust strength, and vibrant health, retaining the precious independence to make your own life choices for many years to come, then I urge you to grant me a mere 10 seconds of your attention. I have meticulously distilled the entirety of the wisdom and actionable strategies I impart to my own patients into a single, straightforward plan, a guide that has already empowered thousands of individuals to live their absolute best lives after the age of 60. The direct link to this invaluable resource is conveniently displayed on your screen, negating any need to frantically jot down notes. I simply encourage you to explore it once this video concludes. Furthermore, if the insights shared within this discussion prove beneficial to you, I would be profoundly grateful if you could extend one small yet significant favor. Subscribe to my channel, express your appreciation with a like, and share your thoughts in the comment section. These actions collectively amplify the reach of this vital information, ensuring it finds its way to more people who desperately need to hear it. Now, let me pose a thought-provoking analogy. If you were to subject a brand new car and a vehicle that has traversed 200,000 miles to an identical, rigorous stress test, would you realistically anticipate identical outcomes? The answer, of course, is a resounding no. And yet, for far too many decades, the medical profession, in its approach to surgical interventions, often treated a 70-year-old body with the same protocols, the same recovery expectations, and the same timelines typically applied to a 40-year-old one. While this archaic paradigm is gradually beginning to shift, the pace of change is regrettably not fast enough to adequately address the immediate needs of our aging population. It's crucial to understand the intricate physiological processes that unfold within an older body when it undergoes general anesthesia. The heart, already potentially strained by years of function, is compelled to work considerably harder to maintain circulation. The lungs, with their diminished elasticity and clearance capacity, take a significantly longer time to metabolize and expel the anesthetic agents. The kidneys, whose filtering efficiency naturally declines with age, process medications at a slower rate, potentially leading to prolonged drug effects or accumulation. And then there's the brain, the organ whose response often catches people by surprise. Under general anesthesia, an older brain can become temporarily disoriented in ways that extend beyond the immediate post-operative period, frequently lasting for weeks, or even disturbingly, for several months. Medical professionals have a specific term for this phenomenon: post-operative cognitive dysfunction, POCD. In patients over the age of 70, POCD manifests with a far greater frequency than is commonly acknowledged or openly discussed. I wish to articulate this point with absolute clarity. Age, in isolation, should never be the sole determinant for avoiding necessary surgery. Indeed, I have personally operated on robust 80-year-olds who have bounced back from complex procedures with a vigor and speed that often surpasses that of some 50-year-old patients. Age, in essence, is merely a number. However, frailty is a profoundly different matter altogether. Frailty, a precise medical term, denotes a state where the body's physiological reserve, its capacity to withstand stress and recover, has fallen below a critical, life-sustaining threshold. Statistical data underscores the prevalence of this condition. Approximately 40% of individuals over the age of 75 exhibit signs of frailty, a number that escalates dramatically to nearly 60% for those aged 85 and above. Therefore, the truly pertinent question, the one that should guide critical medical decisions, is not simply whether a patient can endure the immediate stress of the operation itself, but rather whether they possess the resilience and physiological reserve to successfully navigate the arduous and often protracted recovery period. These are two profoundly distinct challenges, and this crucial distinction will profoundly impact the discussions surrounding the surgical procedures we are about to examine. Surgery number 1, open heart surgery in frail patients. Coronary artery bypass grafting, more commonly known as CABG, or simply bypass surgery, stands as one of the most frequently performed major surgical interventions in older adults. The underlying principle is deceptively simple. When arteries supplying blood to the heart become dangerously blocked, the surgical team reroutes blood flow using grafts, effectively bypassing the obstructions. For the appropriately selected patient, this procedure can indeed yield remarkably beneficial outcomes, dramatically improving cardiac function and quality of life. However, what the glossy hospital brochures often fail to convey is the inherent brutality of this intervention. Open heart surgery mandates the complete cessation of the patient's heart function. During this period, the patient is connected to a sophisticated cardiopulmonary bypass machine, a device that temporarily assumes the vital roles of both the heart and lungs, circulating and oxygenating blood while the intricate surgery is performed. For a vigorous 60-year-old in excellent physical condition, this temporary reliance on a machine is generally manageable. Yet, for a 78-year-old patient already contending with compromised kidney function, the subtle complexities of mild diabetes and the insidious presence of cognitive decline, that very same bypass machine represents a profound simultaneous assault on virtually every organ system within the body. Numerous studies consistently demonstrate that in frail elderly patients, open heart surgery carries an alarmingly high risk, a 30 to 40% chance of experiencing major complications. These devastating outcomes can include debilitating strokes, acute kidney failure, prolonged states of confusion and disorientation, and extended periods requiring mechanical ventilation, significantly increasing morbidity and mortality. Furthermore, a statistic that often stuns individuals into silent contemplation is that up to 15% of high-risk elderly patients undergoing this surgery do not survive the initial 30-day post-operative period. Given these formidable risks, a crucial question arises: what viable alternatives exist? Encouragingly, in many contemporary cases, a powerful alternative is indeed available. It is known as TAVR, or transcatheter aortic valve implantation, a revolutionary catheter-based procedure that, crucially, never necessitates stopping the heart or performing an invasive open-chest incision. While perhaps less dramatic in its surgical approach, TAVR is incomparably kinder to an aging body, a body that fundamentally requires gentle care and meticulous preservation, not a brutal, all-out battle for survival. Does this imply that you should automatically refuse heart surgery? Absolutely not. My message is not one of blanket avoidance, but rather one of informed empowerment. It means you must engage your surgeon with one pivotal question. Am I a suitable candidate for a less invasive approach? The profound implications of that single question alone have the potential to fundamentally alter the trajectory of your treatment and recovery. Surgery number 2, aggressive spinal surgery. Chronic back pain is an almost ubiquitous experience for individuals in their 60s and 70s. In my practice, I genuinely cannot recall a single patient over the age of 70 who has not, at some point, voiced concerns or complaints about their back. Increasingly, the solution frequently offered for this pervasive discomfort is spinal surgery, encompassing a range of interventions such as fusions, multi-level decompressions, and the insertion of various hardware devices along the spinal column. It is imperative that you fully comprehend the following distinction. Some spinal surgeries are unequivocally necessary and life-saving without question. For instance, a spinal cord that is actively compressed, leading to a loss of bladder control or progressive paralysis, demands immediate and decisive surgical intervention. However, when we consider elective spinal fusion for chronic degenerative back pain in an elderly patient, the cumulative evidence gathered from extensive research becomes genuinely troubling. A landmark study meticulously published in the prestigious journal Spine revealed that for patients over 65 years of age, complex spinal fusion procedures were associated with an alarming complication rate exceeding 40%. To put that into perspective, nearly half of elderly patients undergoing these extensive procedures experienced a significant adverse event. And these complications were far from minor. They included potentially life-threatening blood clots, persistent infections, mechanical failure of the implanted hardware, and a phenomenon known as adjacent segment disease. This latter complication occurs when the vertebrae situated directly above and below the fused segment begin to deteriorate and break down prematurely because the biomechanics of the entire spine have been irrevocably altered. The rigid hardware immobilizes one section, forcing the adjacent segments to absorb disproportionate stress and strain. What I find most profoundly frustrating about this particular category of surgery is the often illusory promise of pain relief. Numerous studies have unequivocally demonstrated that for a significant number of elderly patients suffering from degenerative spine disease, aggressive surgical intervention provides no superior long-term pain relief compared to more conservative, non-invasive approaches such as rigorously structured physical therapy and precisely targeted injections. To reiterate, no better pain relief, yet accompanied by a dramatically elevated risk profile. I am reminded of a profound observation made by a former colleague, an exceptionally brilliant spine surgeon, who once candidly remarked to me, "Sometimes the best operation is the one you don't do." That sentiment resonates deeply with me and often guides my own clinical decision-making. Have you ever been informed by a medical professional that surgery was your absolute only recourse for managing back pain? I encourage you to share your experiences in the comments section. I am genuinely interested in understanding how many of you have heard those precise, definitive words. Surgery number 3, major cancer resections. This particular category of surgery presents perhaps the most emotionally charged and difficult topic to discuss, primarily because when an individual is confronted with the stark, terrifying word cancer, the instinctual reaction is immediate, powerful, and almost universally consistent. Cut it out, remove it, eradicate it completely. I understand this visceral response with profound empathy. I too would likely feel precisely the same way. However, 2 decades immersed in the intense world of surgical practice have imparted a critical, nuanced lesson. The ultimate goal of any cancer treatment must extend far beyond the mere eradication of the tumor. The overarching objective is, and always should be, to afford the patient more good years of life, And sometimes, not always, but sometimes, undertaking a major, aggressive surgical procedure in a frail, elderly patient can inadvertently achieve the precise opposite of this noble goal. Let me illustrate this with a concrete, real-world example. Pancreatic cancer surgery, often referred to as the Whipple procedure, is widely regarded as one of the most intricately complex and physiologically demanding operations performed in all of medicine. During this formidable procedure, surgeons remove the head of the pancreas, a portion of the small intestine, the gallbladder, and a segment of the bile duct. The surgery itself is marathon-like, typically requiring 6 to 10 grueling hours of precision and endurance. In younger, otherwise healthy patients, the Whipple procedure can indeed be a life-saving intervention, offering a chance at prolonged survival. Yet, consider an 80-year-old patient already grappling with pre-existing heart disease and significantly reduced kidney function. In such a scenario, the surgery may be technically successful, the tumor may be entirely removed, but the patient may nonetheless succumb within weeks to a cascade of post-surgical complications, not from the cancer itself, but tragically from the devastating impact of the operation. This somber outcome is medically termed futile surgery, and it occurs with a greater frequency than anyone within the medical community cares to openly acknowledge. A landmark study conducted by the American College of Surgeons revealed a deeply concerning statistic. Nearly 1 in 5 elderly cancer patients who underwent resection experienced failure to rescue. This chilling phrase means that a significant complication arose, and the patient's already weakened and diminished body simply lacked the physiological reserves to recover from it. So for cancer patients, what is the truly worthwhile conversation to have? The most empowering question you can pose to your oncologist, and it should be asked directly and without hesitation, is this: if we choose not to operate, what would watchful waiting, radiation therapy, or targeted therapy look like for someone of my specific age and current health status? That single incisive question has the power to unlock a door that many patients never even realize exists, revealing a spectrum of alternative treatment pathways. And sometimes the answer that lies behind that door is genuinely, unequivocally better for the patient's overall well-being and quality of life. Surgery number 4, elective joint replacement in severely ill patients. Hip and knee replacements are widely celebrated as being among the most successful and transformative surgical innovations ever developed. I state that without any reservation whatsoever. For the carefully selected, appropriate patient, a new hip or knee can genuinely revolutionize their quality of life. Individuals who once struggled to walk more than a few painful steps can suddenly return to active lives, even engaging in joyous activities like playing with their grandchildren. It is truly remarkable to witness. However, this is precisely where the complexities arise, particularly for older adults. The operative word here is elective, meaning the surgery is meticulously planned, not an emergent life or death situation. This designation affords you invaluable time to thoughtfully consider your options, time to meticulously prepare your body, and, most crucially, time to critically assess whether this specific moment is truly the opportune one for your unique physiological profile. Because here is what the stark statistics unequivocally reveal. In patients over the age of 75 who are concurrently managing 3 or more serious chronic health conditions, such as significant heart disease, poorly controlled diabetes, advanced chronic kidney disease, or severe obesity, elective joint replacement surgery carries a significantly elevated risk of perioperative complications. Among these, blood clots represent the most formidable danger. Deep vein thrombosis, DVT, where clots form insidiously within the deep veins of the legs, can tragically dislodge and travel to the lungs, transforming into life-threatening pulmonary embolisms, PE. In elderly patients, whose circulation is often naturally reduced and whose blood vessels may be more fragile, this risk is substantially higher than in younger, healthier patients. Add to this the increased susceptibility to postoperative pneumonia, which can result from prolonged immobility in bed, and the heightened risk of acquiring hospital-borne infections, and the overall picture of potential complications becomes considerably more intricate and concerning. I wish to be exceptionally precise in my articulation here, as my intention is not to unduly frighten anyone away from a surgical procedure that could genuinely improve their life. The fundamental question is not, should I ever have a joint replacement? Rather, the more pertinent inquiry is my body currently in the best possible condition to undergo this surgery? Optimizing crucial health metrics such as blood pressure, blood sugar levels, body weight, and overall cardiovascular health in the weeks or months before an elective surgery can dramatically reduce the rates of serious complications. Some progressive hospitals are now mandating formal prehabilitation programs as a prerequisite before scheduling these operations for high-risk elderly patients. This proactive approach, focusing on enhancing the patient's physical state prior to surgery, is precisely the right methodology. Has your doctor ever initiated a discussion about prehabilitation with you before recommending a planned surgery? Regrettably, the vast majority of people have never even encountered this vital term, yet it is a concept they absolutely should be familiar with. Surgery number 5, emergency abdominal surgery. At this juncture, I need to pause for a moment of critical emphasis, as this category of surgery diverges significantly from the others we have discussed. Unlike the planned interventions, you do not choose emergency surgery. Rather, it often chooses you, abruptly and without warning. Conditions such as a perforated bowel, a ruptured appendix, or sudden severe internal bleeding represent acute, life-threatening situations that simply cannot await a calm, considered conversation in a doctor's office. However, the reason emergency abdominal surgery belongs unequivocally on this list is profound. Possessing prior knowledge of these inherent risks before such an emergency catastrophically occurs can fundamentally transform how families are equipped to make excruciatingly difficult decisions during those terrifying, high-stakes moments. Emergency abdominal surgery performed on patients over the age of 75 carries some of the absolute highest mortality rates across the entire spectrum of surgical practice. We are discussing mortality figures ranging from 30% to a staggering 50% in the most severe cases. This is not a reflection of a surgeon's skill or competence, but rather a testament to the brutal reality that an elderly body, suddenly subjected to overwhelming trauma or acute illness, is simultaneously fighting on far too many fronts at once. The liver, kidneys, heart, and lungs, all vital organ systems, are simultaneously assaulted by the physiological shock and stress. Moreover, the robust inflammatory response that a younger, healthier body can typically control and resolve within a matter of days can, in an older, more vulnerable body, spiral catastrophically into a condition known as systemic inflammatory response syndrome, SIRS. When multiple organs begin to sequentially fail under such extreme duress, the situation is precisely as grave and life-threatening as it sounds. So, given this crucial information, what tangible actions can you actually take? There are two primary actionable steps. First, and critically, never ignore abdominal symptoms. Persistent abdominal pain, unusual bloating, or any significant, uncharacteristic changes in bowel habits in an individual over the age of 60 warrant immediate and prompt medical attention. Catching potential problems in their nascent stages means that medical professionals can often treat them effectively before they escalate into life-threatening emergencies. This single proactive habit has the power to alter everything. Second, and equally vital, initiate these difficult conversations with your family now. Do not defer them until you are frantically gathered in a hospital corridor at midnight, grappling with an acute crisis. Discuss your wishes regarding emergency surgery while you are calm and lucid. Articulate what constitutes an acceptable quality of life for you. These conversations, far from being morbid, are in fact among the most profoundly loving and responsible things you can do for the cherished people who will inevitably find themselves standing in that very corridor, facing impossible choices on your behalf. We have now systematically covered 5 specific categories of surgery that warrant heightened caution in older adults. Now, let's pivot our focus to what you actually do with this knowledge, because information, when unaccompanied by decisive action, can regrettably transform into mere anxiety, and that is the absolute last outcome I desire for you. Before contemplating any major surgery, whether it is a planned elective procedure or one that has been urgently recommended, there are 4 non-negotiable questions that every patient over the age of 60 should absolutely ask. I strongly advise you to commit these to memory, or even better, write them down. Question 1. What happens if I don't have this surgery? A truly ethical and proficient surgeon will provide you with a candid, honest answer. If their response indicates that nothing urgent will change in the next 6 to 12 months, then you have been granted invaluable time. Time to meticulously consider your options. Time to seek a crucial second or even third opinion. And most importantly, time to proactively optimize your health and physical readiness. Question 2. Is there a less invasive alternative? The landscape of modern medicine has undergone truly transformative advancements over the past 15 years. Innovations such as robotic surgery, advanced endoscopic procedures, and sophisticated catheter-based interventions have revolutionized treatment possibilities. Options that were utterly non-existent merely a decade ago are now routinely available in most major hospitals, offering less traumatic pathways to recovery. Question 3. What does recovery realistically look like for someone my age and with my specific health profile? The emphasis here is on you, not the hypothetical average patient. The discussion should delve into the specifics of your cardiac health, your renal function, your current medication regimen, and your unique living situation. The answer provided should be detailed and highly specific, not a generic, generalized platitude. And question 4. This is the question that, regrettably, most patients never even consider asking. What is your personal complication rate for this specific procedure in patients over 70? Surgeons meticulously track these statistics. They are intimately aware of their own numbers. A confident, transparent, and honest surgeon will readily provide you with this crucial information. If, however, they appear uncomfortable, evasive, or defensive when confronted with this direct question, that discomfort in itself constitutes valuable information worth discerning. Now, I wish to share a powerful insight that, astonishingly, most patients are never fully apprised of, yet it possesses the capacity to fundamentally alter your surgical odds more profoundly than almost anything that transpires within the operating room itself. If, after careful consideration, you ultimately decide that a particular surgery is the right course of action for you, the deliberate actions you undertake in the 2 to 4 weeks leading up to your hospital admission are of colossal importance. While surgeons dedicate years, even decades, to mastering the intricate details of a procedure, almost no one dedicates 2 weeks to diligently preparing the very body that must not only survive, but also recover from that procedure. Let us collectively rectify this oversight. The first crucial component, which we briefly touched upon earlier, is prehabilitation. This concept can be best understood as rigorous training for a significant physiological event, because that is precisely what surgery is. Your body is about to embark on a marathon while you are peacefully asleep. Therefore, in the weeks preceding your operation, your objective is to systematically build your physiological reserves. Prioritize consuming more protein, as protein is the foundational building block your body utilizes to repair and rebuild tissues. And a significant proportion of individuals over 60 are quietly, often unknowingly, under-eating this vital macronutrient. Engage in daily walking, even if it's just a few laps around your block, because the stronger your leg muscles and lung capacity are going into the surgery, the faster you will be able to get up and move afterward. And the act of getting up, moving, is the single most effective deterrent against the formation of blood clots and the development of postoperative pneumonia, which I previously discussed. Furthermore, if you are a smoker, simply ceasing smoking, even a mere 2 weeks before surgery, can measurably and significantly lower your risk of both wound-related and lung complications. Just 2 weeks, that's all it takes. I have personally witnessed the transformative power of prehabilitation, observing it turn a patient initially categorized as high risk into one who experienced a routine recovery, and its profound benefits cost nothing beyond committed effort. The second vital piece of the puzzle is a conversation that almost no one has, and it's the one you must initiate with your anesthesiologist. Recall the mention of brain fog or post-operative cognitive dysfunction? There are genuinely practical, evidence-based measures that can significantly lower your odds of experiencing it. Request a preoperative anesthesia consultation. Bring a meticulously complete list of every single medication and supplement you currently take, and I mean every single one, including seemingly innocuous items like fish oil supplements and herbal sleep aids, because some of these substances can interact with anesthetic agents in ways that often surprise even seasoned medical professionals. Inquire whether a regional or spinal anesthetic, a technique that numbs only the specific surgical area, thereby avoiding general anesthesia that affects your entire brain, is a viable option for your particular procedure. For many hip and knee operations, regional anesthesia is indeed an option, and it is often considerably gentler on an older brain. And here is a seemingly minor detail that often sounds almost too simple to matter, yet its impact is surprisingly profound. If you wear hearing aids or glasses, explicitly ask for them to remain with you right up until the very moment you go under anesthesia, and to be returned to you the instant you wake up. Patients who can immediately see and hear their surroundings upon awakening experience disorientation and confusion far less frequently. The extensive research on hospital delirium is unequivocally clear on this point, and it is a completely free intervention. The third crucial piece is the aspect that everyone tends to forget until they are directly experiencing it: the meticulously planned recovery setup at home. Strategically arrange your support and assistance before the surgery, not haphazardly after. Determine who will be responsible for driving you home from the hospital, who will stay with you during the critical first few nights. And consider the optimal location for your bed. The fewer stairs you are required to climb in the immediate first week post-surgery, the better your recovery trajectory will be. Proactively clear all rugs and any potential tripping hazards, such as electrical cords, from your living spaces. Fill all necessary prescriptions in advance, thereby eliminating the need to send an exhausted family member to a pharmacy at 9 o'clock at night. The initial 72 hours after you return home are profoundly instrumental in setting the tone for your entire recovery period. A body that is not simultaneously battling the consequences of a fall or struggling with missed medications will invariably heal faster and more efficiently. Be vigilant for any warning signs during those critical first few days: sudden onset of confusion, a fever, or a calf that becomes swollen, hot, or painful. Any of these symptoms warrant an immediate call to your medical team. Do not delay. And the fourth, equally important piece: please, please get a second opinion. I fully understand that this can feel incredibly awkward. Patients often express worry about potentially offending their primary surgeon. Let me emphatically put that worry to rest right now. A truly competent and ethical surgeon expects you to seek a second opinion. In fact, a good surgeon welcomes it, precisely because they would undoubtedly desire one for their own beloved mother or father. Ensure you bring all your relevant scans and medical records so that the second doctor is evaluating the exact same clinical picture. And if two highly qualified surgeons examining the identical body and the same diagnostic images arrive at two distinctly different recommendations, that is not a problem. It is, in fact, invaluable information. That divergence of opinion is precisely the kind of crucial insight you absolutely deserve to possess before anyone even considers picking up a scalpel. None of this comprehensive preparation is rooted in fostering fear. On the contrary, it is about approaching a significant medical event, feeling prepared and empowered rather than merely hopeful. The patient who arrives for surgery strong, meticulously informed, and well organized presents a fundamentally different surgical risk profile than the patient who shows up frightened and utterly underprepared, even when the surgical procedure itself is identical. You possess significantly more control over determining which of those two patient archetypes you embody than anyone has ever truly disclosed to you. There is one more exceptionally valuable piece of information I must impart, and it might well be the most useful of all, because it pertains to the nuanced art of interpreting the surgical recommendation itself. Over my many years of clinical practice, I have come to realize that how a proposed surgery is presented to you often reveals almost as much crucial information as the specifics of the surgery itself. Therefore, I offer you these unmistakable warning signs, or red flags. When you encounter them, it is your cue to slow down, to ask more questions, and to proceed with heightened caution. The first red flag is speed. You perceive a distinct sense of urgency, an insistent pressure to be rushed onto the surgical schedule immediately, perhaps with phrases like, "We need to get you on the schedule right away." Now, if you are experiencing acute internal bleeding or a life-threatening trauma, then yes, rapid action is unequivocally appropriate, and you should absolutely move quickly. However, for a planned elective operation, one that is not an immediate emergency, true urgency is remarkably rare, and a genuine medical professional understands this implicitly. If a knee that has caused you pain and discomfort for a decade suddenly demands immediate replacement this month, you must ask, why this month? The pressure to make a swift decision is almost never genuinely about the immediate needs of your body. It is, more often than not, about a surgical calendar or financial incentives. The second red flag is a single path. You emerge from the consultation with precisely one option presented to you: surgery, with absolutely no mention of any alternative treatments or approaches. Remember, by the time you reach 70 years of age, there is almost invariably more than one viable road to consider. This might include medication management, targeted physical therapy, therapeutic injections, a period of watchful waiting, or a less invasive version of the very same procedure. If none of these alternative pathways were even introduced into the conversation, it is not because they do not exist. It is because, for whatever reason, no one chose to place them on the table for your consideration. The third red flag, and this is the one that patients often completely overlook, is that the do nothing for now option is never discussed. The choice to do nothing, or more accurately, to carefully monitor your condition and pursue conservative, non-surgical treatments, is a legitimate and often highly appropriate medical decision. For a multitude of conditions prevalent in older adults, it is, in fact, the correct course of action. If your surgeon is unable or unwilling to candidly explain what specifically would transpire if you simply chose to wait and closely monitor your condition, then you fundamentally lack sufficient information to provide truly informed consent to any invasive procedure. The fourth red flag concerns how your questions are received. You ask a challenging, probing question. What is your personal complication rate for this procedure? Or, what are my comprehensive alternatives? Or, what precisely happens if I choose to wait? And instead of receiving a thoughtful, direct answer, you are met with a dismissive brush-off, a hint of defensiveness, or a change of subject. A truly skilled and compassionate surgeon does not become defensive when you ask the very same questions they would unhesitatingly ask on behalf of their own family members. If your questions cause the atmosphere in the room to become tense or uncomfortable, pay very close attention to that tension. It is undeniably communicating something profoundly important to you. And the fifth red flag is a recovery process that is glossed over. You hear vague, overly optimistic assurances such as, "Oh, you'll be back on your feet in no time," That, I assure you, is not a detailed recovery plan. It is, quite frankly, a sales line. The honest, transparent version of a recovery discussion sounds fundamentally different. It sounds like, here is what week 1 will realistically entail. Here is precisely when you will require dedicated help at home. This particular part of the recovery is genuinely challenging, and here are the specific warning signs we will need to watch for. Specificity in these discussions is a hallmark of respect for your intelligence and well-being. Vagueness, particularly when delivered with a cheerful, dismissive tone, is a strong indication that someone is attempting to manage your emotional state rather than genuinely informing your critical medical decision. Now, I want to articulate something here with extreme care because its import is considerable. None of what I have just shared implies that your surgeon is inherently a bad person. The overwhelming majority of medical professionals enter this demanding field with an earnest desire to help others, and they work with brutal, unwavering dedication. However, it is also essential for you to comprehend the systemic environment within which they operate. It is a system fundamentally structured around performing procedures, a system that actively rewards the execution of procedures, and a system that often functions on highly constrained 12-minute appointment slots, leaving virtually no time to meticulously walk a patient through 5 distinct alternative treatment pathways. Therefore, the inherent bias toward immediate action is rarely a personal failing of the individual surgeon. It is, more often than not, a deeply embedded structural bias within the healthcare system itself. And the only force that reliably cuts through such a structural bias is an informed, empowered patient, sitting across the desk, audibly and assertively asking these crucial questions. So, what does genuinely good medical practice actually look like in this context? Allow me to illuminate its characteristics so you can unequivocally recognize it when you encounter it. A good surgical conversation is characterized by a deliberate slowing down of pace. The surgeon meticulously illustrates the nature of the problem for you, sometimes even physically drawing it out on paper. They proactively identify and name the potential risks before you even have to ask. They spontaneously articulate what the available alternatives are and transparently discuss the potential outcomes if you choose to wait. And the very best among them will utter the profoundly reassuring words you are hoping to hear. If you desire a second opinion, I wholeheartedly endorse that decision. And furthermore, here is the colleague I would personally entrust with the care of my own mother. When you hear that level of candor and recommendation, you have discovered someone genuinely trustworthy. Hold on to them. And one additional, seemingly small, yet profoundly impactful piece of advice that yields more benefits than almost anything else on this entire list. Never attend a major surgical consultation alone. Always bring someone with you, a spouse, an adult child, or a trusted, good friend. Here's why this matters far more than people typically realize. In my 15 years of clinical practice, I have observed this phenomenon repeat itself with unsettling consistency. The very moment a patient hears a frightening, high-stakes word, cancer, surgery, blockage, a kind of mental fog descends upon them. Their mind immediately spirals to the worst possible scenarios, and from that second onward, they are barely capable of registering another word the doctor utters. Afterward, perhaps in the car on the way home, they find themselves unable to recount even half of what was discussed. This has absolutely no correlation with their intelligence. It is simply the natural, primitive response that fear triggers within the human brain. Therefore, bring a second set of ears, someone calm, someone who is not the direct recipient of the alarming news, and who can therefore genuinely listen and process the information. Have them take detailed notes, or, with the doctor's express permission, record the entire conversation on a smartphone so you can replay it at home when you are in a calmer, more reflective state. And crucially, brief that person beforehand on the specific questions you want to be asked. The 4 key questions, the comprehensive alternatives, the realistic recovery timeline, and the surgeon's complication rate. That way, if the fog descends upon you, they can confidently advocate and ask those critical questions on your behalf. A frightened patient coupled with a clear-headed, well-briefed advocate will collectively make far superior medical decisions than either individual could make alone. Do not walk into the biggest medical decision of your life by yourself when you have the invaluable option of bringing support. Before I transition to what I believe is the most paramount message of today, I want to leave you with something genuinely hopeful. For this video is fundamentally not about instilling fear. It is about illuminating options, and those options have never been more powerful and diverse than they are at this very moment. Minimally invasive surgery has utterly transformed the realm of possibility for elderly patients. Techniques such as laparoscopic procedures, which involve small incisions and camera guidance, dramatically reduce recovery times and post-operative discomfort. Robotic-assisted surgery offers an unparalleled level of precision that even the most skilled human hands alone cannot achieve, minimizing tissue damage and optimizing outcomes. And revolutionary catheter-based cardiac interventions have opened entirely new doors for patients who, in previous decades, would never have been deemed suitable to survive traditional open-heart surgery. Beyond the surgical realm itself, and this is a truth I fervently wish more patients heard, optimized medical management is genuinely a potent force. The careful and strategic combination of appropriate medications, diligently supervised physical therapy, precisely targeted injections, and comprehensive nutritional support can effectively manage a vast array of conditions that, not long ago, seemed to necessitate invasive surgical intervention. The human body possesses an inherent, remarkable capacity to heal. Sometimes, our most profound role as surgeons is simply to remove obstacles from its path and provide it with the necessary tools and support it requires to heal itself. Allow me to share the compelling story of a patient I will call Gerald. Gerald was 71 years old, a retired engineer, and as sharp and intellectually incisive as any person I have ever met. He came to me after 3 different surgeons had independently recommended open-heart surgery for a severely blocked coronary artery. 3 surgeons, 3 recommendations, and the same definitive answer every single time. Gerald, however, was not afraid of the surgery itself. His deepest fear was of losing himself, of becoming a diminished version of the man he was. He had vividly witnessed his beloved wife undergo a major operation 2 years prior and emerge from it profoundly confused, utterly exhausted, and, tragically, never quite the same woman. He confided in me, "Dr. Mandell, she went in as my wife and came out as someone I had to take care of." That poignant sentence has resonated within me ever since, shaping my approach to patient care. When I meticulously reviewed Gerald's comprehensive medical profile, his precise kidney function, his detailed frailty score, his cognitive baseline, I made the decision to sit down with him for an extended, unhurried conversation, dedicating 40 minutes, not the standard 15, to truly understanding his concerns and explaining his options. I told him the unvarnished truth. Surgery was indeed a viable option, but so too was an aggressive, meticulously tailored medication protocol combined with a rigorous cardiac rehabilitation program. The robust data for his specific health profile unequivocally demonstrated comparable 5-year outcomes between these 2 distinct approaches. Empowered by this comprehensive information, Gerald chose the non-surgical path. That was 4 years ago. Last month, he sent me a photograph. He is standing triumphantly at the summit of a challenging hiking trail in Colorado, flanked by his 2 granddaughters, both now taller than him, grinning with an unbridled joy as if he had just won the lottery. Here is what I need you to grasp, for this is the single most important message I will convey today. A surgical recommendation is not a definitive verdict. It is, rather, the initiation of a critically important conversation. You are not a passive recipient of medical decisions. You are, and must be, an active, empowered participant in your own healthcare journey. The very moment you step into a surgeon's office, you possess inherent right to ask every challenging question, to earnestly request every conceivable alternative, and to take every single day you need to make an informed choice. The surgeon may wield the scalpel, but you, the patient, hold the ultimate choice. And that choice, made with full, unbiased information and clear, unclouded eyes, represents the most powerful therapeutic tool in all of medicine. More potent, I assure you, than any operation I have ever performed. Let us now bring all these critical elements together. We have discussed 5 specific surgeries that, for individuals over 60, carry serious and often hidden risks. 1. Open heart surgery in frail patients, where less invasive, gentler alternatives like TAVR now demonstrably exist. 2. Aggressive spinal fusion for chronic pain, where the evidence for long-term pain relief is far weaker and the complication rates significantly higher than most patients are typically informed. 3. Major cancer resections in frail patients, where the paramount goal must always be to achieve more good years of life, sometimes through non-surgical means, rather than simply excising a tumor at all costs. 4. Elective joint replacement in severely ill patients, a situation where meticulous timing and comprehensive preoperative preparation matter just as profoundly as the surgical skill itself. 5. Emergency abdominal surgery, for which the best form of protection is the early recognition of symptoms, proactive medical attention, and candid, preemptive conversations with your family about end-of-life wishes. Now, let me emphatically reiterate, none of this crucial information means you should avoid all surgery. Surgery saves countless lives every single day. I have personally witnessed its miraculous power. I have been a proud part of its life-affirming capabilities. The overarching message, therefore, is this: be an exceptionally informed patient. Do not shy away from asking the hard, penetrating questions. Request every possible alternative treatment pathway. Seek a second opinion, and if necessary, a third. Your age is not an inherent weakness. It is a life stage that demands a more nuanced, thoughtful approach to medical decisions. What single question would you most want to ask your surgeon before undergoing a major operation? Please share your thoughts in the comments section. Your insights are valuable to this vital collective conversation. And if this video has provided clarity, comfort, or empowerment to you or someone you deeply care about regarding a difficult surgical decision, implore you to share it. That one act of sharing might genuinely be the most important thing you do today, extending a lifeline of information to those who desperately need it. Take exceptional care of yourselves. Remain perpetually curious and tirelessly advocate for your own health and well-being. You unequivocally deserve a surgeon who patiently explains every aspect of your condition and a medical team that treats you as an equal, valued partner in your care. And one final critical caveat: everything I have shared today constitutes general medical information, meticulously derived from published research and extensive clinical experience. However, every individual's medical situation is uniquely complex. Therefore, before making any definitive decision about surgery or treatment, please ensure you have a comprehensive, forthright, and unhurried conversation with your own doctor or specialist. They possess your complete medical history. They are intimately familiar with your body and its specific nuances. And that conversation, informed, direct, and unhurried, is precisely where the foundation of truly good medicine begins.